Hey everyone, it's Humpday Happy Hour with Dentist in the Know. It's the full moon. Hinman is next weekend. The International Dental Symposium in Cologne, Germany is the weekend after that, which I'll be at, by the way. We've got some existential questions in dentistry about fluoride, which you can see on Dentist in the Know right now, about dental coding, about medical reimbursement, about all things. What a crazy time in dentistry. And thank God you have Dentist in the Know to help bring you in the know about all of these topics. So tonight, great show. We have Dr. Susan McMahon, incredible cosmetic dentist and a great friend and a great human being. So excited to have her. She's going to be talking everything happening in the cosmetic education world. But before we do that, I want to tell you about my two incredible partners, Dr. Chad Duplantis and Dr. Jennifer Bell, who are here to bring all of you in the know. We are all dentists, we are all educators, and we are all business owners. And we have made it our priority to bring all of the dentists who maybe feel like they're not getting every bit of information they should. We're here to bring all of them in the know. And so, my friends, it's great to see you. And welcome to Dentists in the Know. Welcome to Humpday Happy Hour. And cheers, my friends.
Cheers.
JB, nothing?
Oh.
Lift something up. Thank you.
Oh. Thank you.
Well, now you can cheers. How you guys doing? What's happening?
Guys,
we're just watching you.
Can I get real for a second? Because this is real for all dentists out. This is maybe the most important thing I'm going to tell you the whole episode. This week, it's daylight savings time, a full moon, and a full total eclipse of the moon for a red moon.
At 3 a.m. tonight.
I don't know about you, but in my practice, we already flagged the full moon, knowing that people be crazy during that time, right? What does an hour off their schedule, a total lunar eclipse, and a full moon simultaneously? What does that mean? Is it going to be awful? Is it? I mean, it's kind of been a little.
Well, I was returning your phone call this morning.
Yeah.
And when I was grabbing the phone, I looked up and I saw the full moon because I was leaving at like 6:30 in the morning and it was still really dark here. And I knew you were going to say, hey, how's it going? And I was going to be like, oh, it's not so good because there's a full moon here. And I was like, you know what? If there's a full moon here, there's a full moon there. So, you know.
Oh, crap. Guys.
What?
And Mercury begins retrograde on the 14th.
I'm out.
Screwed. We are screwed.
That's interesting.
What is Mercury being in retrograde mean?
I
have no idea what that means.
So glad that Jeff asked that.
It's when Mercury is in apparent retrograde motion or simply Mercury retrograde. To those who practice astrology, these times were traditionally associated with confusion, delay, and frustration. And I'm going to tell you, I have patients.
That information right at hand.
I have it. I'm just going to tell you, I have patients who specifically will do nothing during Mercury in retrograde. And I don't necessarily practice astrology, but I will say there were times during those time periods where I'm like, that was probably a pretty good idea because XYZ didn't go the way I wanted it to go. So I'm thinking, can I build a practice around only seeing patients when the moon is a tiny crescent and Mercury is in normal grade, whatever normal grade is, and we just practice for the 4 weeks that that's happening, and then we shut it all down because we just can't manage the moon and Mercury simultaneously.
So here's a question. Do they still sell mercury thermometers?
Okay, I'm talking about the planet.
The planet, Chad.
Oh, shit.
Damn
Okay.
it, Chad.
Yeah, well, I had a dog come in and jump on my lap, so I wasn't really paying attention because I was a little bit lost about Mercury being in retrograde. But I'm good with whatever you say.
Okay.
Do you concur, Dr. Duplantis?
I concur. Hey, Jeff.
Yeah. These are not Jenny's glasses.
Hey, Jeff, does Jenny know where her glasses are?
These are not Jenny's glasses. These are actually very cool. And I will
They're
keep saying
Susan's
that.
glasses.
I will keep saying that these are very cool until everybody believes it.
Are they
I
meta
love you,
glasses?
but
Because if they're
those
not
are-
meta glasses,
Yeah, what the hell are those, dude? They look like
I don't know what they are. I stole them from Jenny's dresser.
okay. So they are Jenny's glasses. Okay.
So the best part is I'm like, I think Ellen has a pair of those. Why the hell is Jeff wearing them?
I want you to start wearing Jenny's rose-colored glasses because they make her look really beautiful.
Those
and
are actually pretty badass.
They are
I actually
badass.
love those glasses. They are very badass.
By the way, that's one of the best songs ever
rose-colored glasses.
from John Conley. Yeah,
Yeah, I mean, ever is a strong word, but
it's one of the best songs ever.
But in respect for Dr. McMahon and in respect for our viewers who actually want to hear some stuff about dentistry, I think we should do some news and then let's get on to Susan McMahon.
it is kind of the thing we've become known for.
Yeah.
Let's do it. Let's do news.
Okay.
News.
All right,
Do
team.
news.
Well, I think I've now reported on this story 4 times, maybe 5. The old Corporate Transparency Act. Well, fear not, folks. We have yet another update. And as I sort of predicted the last time I ran this story, I had a sinking suspicion, given our new administration, we would see yet another modification to this requirement as they're sort of culling through a lot of different regulatory agencies and making decisions. Well, fear not, my friends. If you have not yet filed with the Corporate Transparency Act and the IRS to let them know who stakeholders are in your business, you fear not no more. It seems that this has now been permanently postponed. There was yet another court and legal action that came forward. We've seen this ping pong back and forth. The last time I did this news story, we were going to have a mid-March deadline, and that has all been shut down. There's now additional court rulings about unconstitutionality of this particular request out of the IRS for the transparency of your corporate infrastructure. So now the group is going to go back to the drawing board to actually determine who are the entities in which they're most concerned about, the ones that they were ultimately trying to vet out and find foreign ownership within corporate infrastructures. My guess is the majority of us small business owners with dental practices were not their primary target. And we may see that regulation go all the way out. I'll keep you posted if anything changes. But for now, that is the capstone of the Corporate Transparency Act. You can just sit and hang tight until I let you know more. Another big update, the Code Maintenance Committee, which we talk about every year, got together. Now, this group is a compilation of lots of different individuals that have stake in the dental industry. It can be the Dental Hygiene Association. It can be the AGD, the ADA, the Prosthodontist Association, the Periodontist, the Pediatric Dentist, a myriad of individuals. And in fact, you as an individual dentist can put forward codes for revision, change, or addition to the CDT code. So if you've never done that before and you feel really passionate about a modification, I would encourage you to do some more research on the Code Maintenance Committee. They meet once a year. We had our 2025 meeting. The next reconvening of that group will be in 2026. Now, here are a few highlights that you can take notes of for your perusal. Now, remember, none of this will be in effect until 2026, so you can't just go back on Monday morning and start doing the things that we've discussed. probably one of the largest changes that we saw was related to the preventative resin code, the 2391, and also the 1354, I think, which is the preventative resin code. Originally, that code was designed to help provide an alternative. 1352, excuse me, was the code designed to do the preventative resin on Pitt and Fisher caries. You could go in, but you weren't going through Denton in order to treat. Well, that could be modified if the 2391 code was modified, which actually is a single surface composite in the posterior, which dictates the depth of the destruction of decay into dentin. Well, it would appear at least that they have combined these two codes to say now 2391 in the posterior is acceptable for any type of resin restoration, whether it goes halfway through enamel all the way to the DEJ or through the DEJ and into dentin. That is going to be a singular code. So if you've been doing a lot of preventive resins and charging directly to the patient, you can now move that to a 2391 and bill their insurance company for that, because a lot of times the 1352 code wasn't even covered anyway. So that was one of the bigger updates. Another couple new codes that you're going to see. Now we're going to get to see a duplication of a complete denture maxillary mandibular, which means you're going to be able to do, my guess would be majority of us will be doing digital scans of existing dentures to catalog those. And if you need to reprint and deliver those, there will be a CDT code associated with that, because you don't need to charge all the fees associated with the MMR and the wax from Trian and the 2 Trian, et cetera. You're just going to duplicate procedures. So there will be a new code set for that. And also cleaning and inspection of an occlusal guard without adjustment. So when you're cleaning those appliances that are coming back into the office once a year, you'll be able to provide a CDT code and a charge for that. So those are some of the interesting updates that we saw. Over 50 codes, modifiers, and additions, deletions, et cetera, were submitted. The scope of those that make it through the cut of all the different entities, 45 different organizations, in fact, have some stake in the modification of code maintenance each year. And as they debate and work through these different codes based on whomever they're representing at that meeting, they scope into these different additions. We've seen in the past sleep and some other interesting codes have been added. This year, it looked like appliance therapy was the winner of the day. And with that, that's the news.
So here's an interesting question, JB.
Okay.
There currently is no code, although we get reimbursed for an annual visit for appliance therapy for sleep apnea, or if it happens to be a TMJ appliance that has lasted a year, although that's not that common. There is currently no reimbursement for cleaning or maintenance of any of those appliances. Is that something that might carry over to medical, or is that something that we might have to consider billing to dental separately, aside from what we have already billed?
It sounds like to me there's an open opportunity here to at least use that new CDT code for occlusal guard. I think occlusal guard could be kind of a broad sweeping term for TMJ appliances, bruxism appliances. Like occlusal guard has a kind of a broad definition. So you probably could use that, but you could also hypothesize that you could come forward with a new modifier to that CDT code that starts to specifically get into oral appliances and the types. Honestly, I'm more of a fan of these broad sweeping categories. Like it would have been nice if it just said an oral appliance. And as long as the maintenance and care for those oral appliances is relatively the same, dropping it in a Ziploc bag with some tartar material, like tartar
control. Well, the fact it is.
Polishing it up and giving it back to the patient, whether it's a sleep appliance, a TMD appliance, an occlusal guard, a couple Essex retainers, like whatever that happens to be, it would be nice to just have it all lumped into those oral appliances instead of a la carting it out on the occlusal guard, because now that forces us to make a decision. Do we modify the new code in 2026 to say, we could do better? Or now do we have occlusal guard, Essex retainer, TMD appliance, sleep appliance, and add 72 additional codes now for all the different things that you put in. I mean, a partial, a denture, whatever it happens to be that you put in a Ziploc bag with some tartar stain remover and move on. So tough to say. We'll see. Did Jenny bring us a surprise? Oh, thank you.
This just came in from my wife's dresser.
You need to thank me, JB. I texted her. I was like, "Can you please go?
Thank you. Can you please bring him some
Can you
glasses?
please go get your glasses off of your
Yeah.
husband, please?"
If this were
because
just a
it's really
podcast and didn't
disturbing me.
have video, we wouldn't care so much. But honestly, like,
I mean,
Wow, I didn't
seriously,
realize
good
I was
Lord.
what?
embarrassing
Y'all
y'all
have
that
matching
much.
glasses?
Huh?
Oh no, I just had Ellen bring me a pair.
Wow. Okay. You'll know
I
where
still
the
like these. I'm sorry.
over 40, over 50 crowd when we're all wearing our bifocals simultaneously. Are we ready to go?
We're ready
Let's
to go.
do it. I think we need to bring our guest on.
Guys,
What?
you've known Susan. Like,
Can I say I love Susan? Like
You
I've
can
known
say
her
it.
for
I think that's-
so long.
I think we're in a safe space.
Okay,
Yeah,
can
no,
I introduce Susan?
I don't disagree. I don't think that you guys don't love her, but I've known her a really long time, and I just have an incredible amount of respect and love for her. So I can't wait for her to come on.
Well, who's
Who
going to
wants-
click the button?
I'll click the button. Who wants to introduce her?
Sounds like Jeff does.
No, I'm going
I don't
to.
have her
Oh,
bio.
Chad's going to do it. Okay, fine, Chad.
So I'm not even going to read her bio, but I'm just going to say
I don't need to either. But
That's
I
when
didn't
you know
wanna
you're a
miss
friend
anything.
of the
This
group.
is one of my favorite people from Pittsburgh, Pennsylvania, who is hiding away in Kiowa Island, South Carolina right now. But I
Again?
will just say that there have been 2 encounters within the past couple months where it's been a breath of fresh air to see Susan. One is getting off the plane in Aruba. The first person I
Yes.
run into is Susan. And it's like, oh my God, my Susan's here. And then a couple weeks ago, I was in California at the Glidewell event. And it was an event that was kind of quiet. And I didn't really know who I was going to know that was going to be there. And I'm in the hotel on Saturday morning, heading to the event, and who do I see but my Susan, my favorite Instagram cosmetic dentist from Pittsburgh, Pennsylvania, and one of my favorite people to always be around. It's great to see you.
Hey, back at you, Chad. Hey, Jeff, what happened? We were twinning.
Twinning.
I
Screw
thought
it.
I was channeling Bob Margis.
Oh, yes,
I know,
totally.
right?
Yep. Well, I'm happy to be here. You know, I love all of you guys, and Aruba and California was especially awesome because we got to spend a little time together, Chad.
Yeah.
That was pretty
Like
amazing.
real time, you know,
Yeah.
not just,
Real time.
hey, see you at the airport. Bye.
Yeah.
Mhm.
Yeah. So, and then, hey, I got to tell this little story. So when we were in California, we had this speaker trainer on Saturday afternoon who was a really, really nice guy. And he's been doing this for a while. Let's just put it that way. Broadway trained actor. And on Saturday night after the event, we all get back to the hotel and I think Susan and I and a lot of the other people thought this guy was just going to disappear. This guy freaking closed down the bar with us on Saturday night. And we had the best conversations with him and learned so much about New York and speaking. He was just a gem of a human being. It was awesome. It was really a great night. So
I agree. It was a fantastic night. Tom Muccelli, is that his name?
Tom Mucciolo.
Mucciolo.
Yeah.
Mucciolo. Yeah, he was phenomenal. I learned so much from him, and he was just so much fun and such a wealth of information. Had a million celebrity stories and just a lot of really good stuff.
Yeah, he was actually sharing with us because it was the week of Gene Hackman's passing, and he was sharing with us that he was actually in a movie with Gene Hackman. And he was in a scene at Grand Central Station, and he just a neat guy, just a really, really neat human being.
I think that could be super valuable because he did like lecture prep and how to reach your audience. Is that what he was focused on?
It's kind of like presence on stage, positioning, all the things that we don't think about as dentists, right?
Yeah.
But as an actor, he brought it all to us.
Lots of hand motions.
To us.
Yeah.
Open palms.
Don't you think dentists in general could really benefit? Like, even if you have no desire.
I'm not quite sure what to do.
Yeah, Ricky Bobby, put your hands down.
Yeah.
But don't you think as dentists, half of your job, other than the technical skill, is an act that we play? Like, in a very holistic and very wholesome way. It's selling your idea of why you believe what you believe, how you believe it can take them from point A to point B, communicating those ideas clearly, concisely, and effectively, your presence and confidence in a treatment planning discussion to say, I understand what you need and I can carry you hopefully to that endpoint. And if you don't understand, you're also very honest about that. And you're like, this is not a great idea, but if this is the one you want, then I'll walk that journey with you, but I'm not taking ownership of that. I'm going to give that right back to you. Like, I feel like all dentists could benefit from that type of training.
I think we all agree, but I'll tell y'all, Jeff and Susan and I were in a meeting, and one of the best speakers I've ever seen is Ron Kaminer. And Ron Kaminer, he actually has a part of his presentation where he talks about changing your tone and counting exercises and all this stuff for learning how to speak. And he's talking about speaking to the patient. And so the three of us, Jeff and Susan and myself, we were in this speakers training several years ago. And Ron, one of the best speakers we've ever heard, gets like in a trance from this speaker. Do y'all remember how much it screwed him up for like a month? Like he was like robotic and he couldn't figure it out. And he's trying to do all the hand gestures and trying to mimic what they were teaching him. It was crazy. But yeah, I think all of us, not as speakers, but as dentists, we could all benefit from some sort of speaker training just as a communication exercise.
Communication for sure.
Yeah.
Right. I have a new associate at work, and that's exactly what we've been working on. There's, like I'm telling, there's always two things: confidence and connection, right? And sometimes you have to really work on connecting with patients. You have to work on your technique or your maybe approach, like you said, Jen, to connect with those people, because you got to connect with them almost right away.
Yeah.
And then the confidence to tell them what you think they need to have done.
Do you have any, do you have a methodology that you're currently using with your associate? Like, do you have a book, a pathway, a checklist, both from a technical? I think a lot of people would benefit from hearing, like, as you're a very experienced dentist and you built a practice that has a very niche market in your community and you've built it the exact way you want. And then I'm making an assumption, so please correct me. Bringing an associate into that environment can be challenging because you're trying to elevate them to your same skill set and kind of get them into that. So for doctors who are bringing in associates, whether they're in a niche market or just, run in the mill dental office in their hometown, do you have a methodology that you've adopted or a plan of attack? Are you trying it out and we can learn from your wins and losses? Like, what's your thought process?
Right. Interesting. Right. So this associate has really great skills. Like, she already has skills. So right, you have to have the skill set to do it. And she's a really good diagnostician, but it's conveying that to a patient when you're new. And I think it's also challenging when you've got like a senior doctor, which I hate to call myself a senior doctor, but that's what it is, right? You've got a senior doctor. Sometimes those patients are expecting to see the senior doctor, and you've got to go in there as the new person and really be confident, but at the same time, get the job done, right? Like, present what you need and get the job done. So we're actually working on a program to scale that, if you will, to scale that to other doctors. But the thing that I say to her all the time is, stop talking and start listening. Mm-hmm. Listen more, talk less. Like, every time you want to go and explain, you just got to be quiet. You got to sit in the silence for a minute, because that's when the patient says things to you that are so important. That's when you find out if they think what you're presenting is what they had in mind, if it's not even close to what they were thinking. It's the silence that's so hard for everybody.
I'm going to jump in
love
one
what
more
you
time,
said.
Jeff. I'm going to jump in one more time, and then
Go
I will
ahead.
be quiet
Hey,
the rest
Jeff,
of the
just
episode.
please be quiet, Jeff.
Silence is the
Silence!
I'm
Silencio, por favor.
I'm just going to
Yeah.
put my glasses on and look good.
Glasses back on.
I love this topic so much because
do
I think
too.
I am reflecting back on myself as a young provider, and I struggle with confidence so much. And you do talk almost to convince yourself as much as the person sitting in the chair that you can in fact do the thing that you're convincing them to do. So you're just talking in a circle going, yeah, I mean, I think this is what we should do. And I think I am the one to be able to do that for you. Like,
Right.
as your confidence grows, your lack of trying to convince other people to walk that journey with you does taper a bit. But I totally can resonate. I can think about myself in that time. And I was like, yeah, I definitely was selling myself as much as I was selling dentistry. Like, not only do you need a DA2, but I think I could be the person that could do it. Like, I think maybe I'm the one.
So the best piece of advice I ever got was from a patient, and it was probably my second week in practice. And this guy needed a crown on tooth number 13, and he was a colonel in the Army, right? And so I went into this very lengthy explanation as to why he needed a crown on number 13. And I just would not shut up. I was going on and on and on. And finally he goes, "Stop it." And I sat there for a second. He goes, "Is there a moral to this story?" And I go, "Yes, sir. You need a crown on tooth number 13. Then let's schedule it. And can I get the hell out of here?" He comes back the next week. We do a crown on tooth number 13. All right. Fast forward. And this is so relevant to this week. Fast forward this week. I've got this guy in, and he was a colonel in the Air Force. And he needs a crown on, I can't remember what tooth. This was Monday. This is how bad it is. I could remember from 25 years ago, but I can't remember from Monday what tooth it was. And I tell him, and he goes, "All right, when do I need to get this done?" And so I hate it when patients ask that, because my answer is always like, I don't have a crystal ball, but I'm going to say within the next 3 months. And he looks at me and he goes, "Stop it. Do I need to schedule it when I walk out, or can I do it when I come in 6 months?" I go, "Schedule it when you walk out." And he goes, "Thanks. All I need is a little direction. We're done." And this guy's been a patient for a long time, but it's the two colonels have really pushed me in that direction of less is more.
But that's not the case with every patient, right?
Oh,
like
no.
This is the whole understanding of different personality types. There are those personality types that just want to be told what to do, when do I need to do it, and let me schedule. Then there's the personality types that want to understand every little frigging detail of what you're going to do before they will even consider making a decision. And that's why it's important to understand personality
100%.
types. But to
100%.
Susan's point, I think the thing about listening, and this is coming from a guy who talks way too much. The thing about listening is that every patient will tell you what's wrong with them if you listen long enough.
Yeah.
Like, you will get more diagnosis from the patient explaining what has happened in their past than you will get from any exam that you will do. And so I think that, again, just taking this full circle, Susan, to your point, that thing about listening, listen, give them the opportunity to talk as much as they want, because they're going to tell you so much about their history that will allow you to provide treatment that will last for a long time.
Agree. I totally agree. I think that's the most important thing. I think, and the other thing we're always talking about is patients, like you said, Jed, they want to be cared for. They want to be taken care of. If you take care of them, if they think you care about them and you do care about them, and that's coming through, patients are, much more willing to move forward with treatment, I think.
Totally agree.
100%. Yeah. All right.
All right. For people who don't know you, Susan, let's talk a little bit about your journey. Let's talk a little bit about what you're currently involved with, because you've got the Mommy Dentist and Business Group. Like, you're involved in quite a few things, your own speaking opportunities and your own practice, etc. Just for our audience, just a little backgrounder.
Yeah. So I practice in Pittsburgh, where I practiced my whole career. I started off as like a PPO dentist and, an insurance-based practice, and kind of slowly weaned off of that to fee for service for about 15 years ago. I was with a DSO for a little while, so I had that experience. And now I'm in a private practice with an associate, and I have a periodontist in the office, and I do a lot of teaching, which I really enjoy, which is how I know all of you guys, because we see each other out there in the world. So I teach technique, cosmetic technique. I teach whitening, and recently in the last 5 years, integrating digital technology. And I've been fortunate to be involved with some pretty awesome women's groups recently as well, because it's, like a incredible thing that, women are taking more leadership roles in dentistry, and we're being more equally represented, I guess we should say, as we get bigger and bigger numbers of practicing women dentists. So I've been involved with the Mommy Dentist in Business since its inception, and it's a great group of ladies, oh my gosh, 20,000 women strong, I think now, that has teaching events, there's social events, and all sorts of support for women in dentistry. And also Glidewell has that fabulous program called Guiding Leaders, which is new this year. They're opening it up to all dentists. So that was a women's only thing for the last 5 years. I was there in 2019. So in the first group, it's a leadership training for dentists. It was just women dentists, and now it's opened up to everybody. And I think they're going to take 50 dentists every year and do this incredible leadership training and some speakers training and sort of executive training that we never were exposed to before. That's sort of cool. And I'm also got a couple of new things happening for me. I'm just about ready to launch a platform called Smile Concert, and that is a mentoring platform for dentists. So, and you guys probably get the same thing. Every time I'm out giving a lecture, at the end of the lecture, 4 or 5 dentists come up and say, hey, can you take a look at this case? I don't really know where to start with this. Oftentimes it's their family members, right? And for me, it's mostly cosmetic oriented things. It's veneer cases, dark teeth, crowding, failing dentistry, things like that. And this Smile Concert is a platform that has a panel of docs like me. And you will be able to upload your case digitally to it and then consult with sort of a mentor the whole way through your case. How do I treatment plan this case? What fees do I have for this case? How do I present this case? What does my team need to do? What lab should I use? And there's a dashboard on the site that'll allow you to track your case the whole way through and talk to your mentor whenever you really need help. So kind of like start to finish, someone on your shoulder giving you a hand.
That's so awesome.
Yeah, I'm excited about it.
So, there's something, and it kind of relates to what we've been talking about that I kind of want to hit on a little bit tonight. And it's maybe case presentation is what you'd call it. But A, how do these patients find you? B, how do you talk to them about maybe their aesthetic? How do you approach the aesthetic cosmetic needs? Let's say there's a patient that maybe the patient that comes in seeking it, or the patient that comes in and you think that they might need it. And how do you quote unquote close the case? I mean, I know that's very open-ended, but can you touch upon some of those points throughout this?
Sure. Let's back up just a little bit, because I start every lecture like this, that I see a lot, almost every patient that I see in my practice in Pittsburgh, and I've been marketing in Pittsburgh for many years, so I see a lot of smile consults in my practice, but almost every single patient that comes to me is coming from a dentist. They have a relationship with a dentist. They've been with them for a long time. And I'm always like, what are you doing here? They're looking for veneers. They're looking for redoing their work. And they say things like, well, I just didn't think my doc did this, or I asked about it and the doc was like, no, your teeth are fine. You look great. Like, especially for younger people that come out of ortho and look pretty good, but they're not, it's not everything they want it to be. Right. Or they'll say things like, well, I talked to my doctor about it and I just didn't she did a temporary for me a few years ago and it didn't look great. So I was afraid to do that again on my front teeth. So they're leaving all of our practices and seeking care other places for lots of reasons. But most of the time it's because they either didn't think their dentist did it or they never talked to their dentist about it. Oftentimes that happens. So I say in general practices, we got to kind of let them know that we do that. And one way to do that is on your health history form. Every time you update it, ask, are you happy with the way your smile looks? And would you like whiter teeth? Those are the two questions we have asked. And at any time the answer is, are you happy with the way your smile looks? And it's on a digital form, so you have to check yes or no. Anybody that checks no, it gives us an opportunity to kind of talk to them. Hey, let's take some pictures and talk about it. And we don't say like, what don't you like about your smile? Because people clam up about that, right? They say, let's take some pictures and we'll talk about what can happen. And it gives every dentist an opportunity to talk about it. And I think that's part of the reason that these patients are out seeking care in other offices is because they never talk to their dentist about it.
Is there, this brings up a kind of a personal question. Is there ever an awkward situation where you run into a dentist that maybe had a patient referred to you or that heard of you that's kind of like, hey, I hear so-and-so's seeing you now for this. Is there anything, you have to have come across that?
Oh yeah, for sure.
Oh yeah.
One of my favorite ones is I had a patient that came in that, had like a lot of composite work and a lot of amalgam and, just wasn't looking great, a lot of wear. She was probably about a 70-year-old lady and she just wanted to look better. And her dentist was her son-in-law and someone I know very well. And she's just like said, he just, keeps patching me in. I don't want to do that. So, what I'm going to say, okay, great. Let's do it. Here's what I can do and let's do it. So we did it all. And when we're done, she said, do you think he's going to notice?
Oh, shit.
Oh, I think he's going to notice.
Yeah. And then he's definitely going to notice.
He's going to notice. Sometimes I get blowback from it and sometimes I just don't, right?
Yeah.
But you know how it is when you lecture in your own city, which doesn't happen that often, right? We're traveling all over the place.
Yeah.
But on
No,
Wednesday,
you are only an expert if you are from 500 miles away or more.
Yeah.
Mm-hmm.
Yeah.
All right, I have another question then. So let's go back. Let's train and educate those doctors. I have found myself in this very situation. I see things could look better. I see we could improve stuff. Maybe it's just tooth movement. Maybe it's restorative dentistry, whatever. And doctors are thinking, I don't want to say your teeth don't look good. Things don't look great. Like aesthetically, it's not awesome. Even if it's just whitening, like, you really could benefit. So let's role play, kind of massage the conversation a little bit. Like if I'm the restorative doc who's losing all my patients to you and I'm going back humbled going, okay, I'm not letting patients walk out the door anymore without me being real and honest about what I can do and what my skill set is. Because I've actually had this happen to me too. So this is very real. What are some things doctors can do? What are some like windows that get open? They can kick the door in and say, oh, let's talk about that.
Yeah. I think, well, the easiest thing to do is take photographs on your patients. An intraoral scan, but it isn't quite as powerful as a photograph, I think. We always have the scan up in the room. We take 4 quick photographs. I load them up on a laptop. I sit down next to the patient. I open that laptop up and you don't even have to say anything. They look at their teeth and they're like, "Ah, I don't want to see that." Or it's very powerful.
Yeah.
I don't have to say, I think we could do something. uh, you know, it's very powerful just to sit there and open it up. That's another time you just have to be quiet and let them talk.
Let them
Just let them
speak.
talk, right?
Yeah.
Sit there and we used to have a big screen, but now I do it on a laptop. So that is powerful. I think we have to be really cognizant about how we do it is when it's with younger people, because lots and lots of young people, really young people, 13 to 25 years old, are consumed with the way their teeth look now. I see a ton of consults for this, and you see them too. Like, right? They're all talking
Yep.
about it, and I never want to put into somebody's head anything that would make them think they're not perfect in every way, right? Like there's so much pressure on them in so many other ways. I would
Absolutely.
never want to add to that. But at the same time, we want to make sure we address it. And that's like asking that, are you happy with the way your smile looks, really can be powerful. Because if they say no, you can say, let's talk a little bit about that. And then again, be quiet, and hopefully they're talking about it and giving you some sort of direction on which to go. So, it's two different things. I think, adults, I open up that picture, I just kind of sit there and think, or sometimes I'll just say something like, I'll just look at my assistant, look at the picture, and just, and not even say anything. And then it gives them a time to say, yeah, that crown's terrible. I wish I could have got rid of that, or I would like to get rid of that, or what can you do for me? And then we talk about it with some cases that we've already done.
So, Susan, let me change directions and ask a completely off the wall question and say, I'm talking now from maybe some of the dentists out there who think, okay, cosmetic dentistry, veneers, full mouth rehabilitation. How has cosmetic dentistry changed? And what are some of the things that you're talking about now that maybe newer dentists that are just coming in that have always thought of cosmetic dentistry as, oh, they're just going to teach me how to do veneers? What are some of the things that you're talking about now, and some of the newer sides of the cosmetic world that most dentists need to be exposed to?
That's such a great question. I know, because a lot of us just think, oh, full sets of veneers, 10 veneers on the top, 10 veneers on the bottom, right? Full mouth rehabilitation. But there's so much of what I'm doing now is in composite, because the composites are so fantastic now, right? And also, there's the whole digital world that has changed it's leveled the playing field for so many of us. So you can take a case, you can digitize your case, intraoral scan some photographs, marry those things together, get a smile design, have a stent made, and then do injection molding on a stent to do like very reasonably priced veneers for somebody, or tweak the smile a little bit with some injectable material. Chad and I just saw that Clinician's Choice injectable material a couple of weeks ago that was phenomenal. Like,
It's kind
there's
of why I
just,
asked this question, because
yeah.
that post got a lot of recognition, and I think it needed to. Like, this is some of the stuff that I want to come into the mainstream of dentistry that I hoped you would talk about a little bit tonight as well.
Yeah, and it can be, a really great procedure for us in that it can be a good use of our time and lucrative for our time. But at the same time, it is life-changing, especially for these younger people. It makes a huge difference in their confidence and their self-esteem and the way they present themselves out in the world. And a lot of times it can be, absolutely conservative, or even non-prepping at all. So, and a lot of time, like freehanding, composite, that is hard,
It
right?
is hard.
It is hard. I
Yeah.
hate to do it, but if you get the digital help, you get a digital smile design. You can make a stent from it. You can inject into it. You can do really conservative, even if you're going to do veneers, conservative veneers with the help of the digital world. So there's so much stuff. Printing, we've been talking a ton about that. The printing makes everything so accessible now too.
And you have to love, I mean, even I find myself when I talk about the difference between a chairside veneer and a laboratory veneer, pros and cons. Like I find myself gravitating towards the chairside veneer because I can take away and I can add. So if you chip it 5 years from now, I can modify it and make it better. And the permanency of porcelain has amazing value, but also like kind of scary. And how does it wear and perform over time? And there's some, as I call it, composites like our dental Play-Doh. Like there's something about the ability to add and subtract that's really powerful.
Right. And there's a value in that too, like
Right.
a value for the patient, right? Porcelain veneers can be very pricey.
Absolutely.
And it's not a rarity anymore because we have lots of patients whose parents are walking in waving their credit cards. Like, well, we want porcelain veneers, Thank you, Kardashian Jenner family, for that. But if you do composite veneers, you could do that really pretty relatively inexpensively, or less expensive than like traditional veneers. And if like the sheen goes away in 5 years, you polish it up again.
Yeah, no problem.
Right? Yeah.
All right. I have an odd question because we've actually never talked about it on the show before, but in many of the cosmetic lectures that I've seen, they talk about biomorphism and the concept of you go in and you do something so fundamentally different than what the patient used to be. And while for us academically, 100% acceptable, looks great, function, form, like we hit it on all pieces. And yet it feels foreign to the patient. Like they can't quite. Number one, have you ever experienced that before? Because I have, and it's a very weird situation to find yourself in. And two, if you have any advice or, any thought on that particular issue.
Right. I've definitely experienced that.
Okay.
People's expectations sometimes doesn't align at all with reality or with what we would prefer to do for them. Right. Coming to mind, I have a patient that said, make me the biggest, whitest teeth, whatever you're thinking, more, bigger, whiter. And we went through, 6 or 8 sets of provisionals, bigger, 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 till I had to say, I can't do it any bigger. There's no more bigness that can happen here. But I know it is a difficult thing. And a lot of it has to do with managing patients' expectations. And for me, like the work that I'm doing, hopefully, like I always consider it a success if you can't tell I was in there.
Right.
It just looks like nobody was there. No dentist was there. I have made plenty of those big honking white teeth because people ask me to.
That's
right?
The 1M1.
Great. Yeah. But I never show them in my lectures. You won't see them in my patient presentation. And I always tell them, don't tell anybody where you got these because I don't want more people like that.
But here's my point. We should show that at lectures and say,
right. Or I was actually thinking Steve Harvey.
I was thinking most Steve famous Harvey. Cases.
Yeah.
That's pretty.
Yeah.
We should show that at lectures. I mean, this is how we need to transfer information. It's like, honestly, just because we can doesn't mean we should. Right? Like
truer words have never been spoken.
Yeah.
Right.
Well, and Susan brought up a really great point. Going through 6 temporary sets means you're investing in the temporary phase. And a lot of doctors, particularly young in their career, that's just a means to an end, right? We're just putting the temporaries on to get the final cemented and done. And we believe and are totally bought into the concept. The ceramist is going to fix it. Don't worry about it. It's fine. The bisacrylic's like shit. Don't worry about it. We're going to solve this in the ceramic phase. It's fine. Guys, I speak from what I know. And then they don't like the finals, or you go through and it costs so much more money.
Put when you're in the big ass bleach temporaries and let them see it. Right. Exactly.
Right. I'm thinking now a PMMA block. And then you just draw axial lines in.
Yeah, good idea.
And then we've got that big honking white tooth.
Barney.
Right.
Is he still around? No.
But what a great point, because how many times do we see this where a patient comes in, they're like, I want to go way lighter. And then we make a set of temporaries that looks like their natural teeth.
Right. Or even a B1. Or maybe just a B1.
And then the permanent restorations come in that are a completely different shade. And they're like, oh, I didn't know it was going to look like that. Like, I told you that may be a little too light for what you're trying to do if you want a really natural look. And so I think the temporization phase, and I think that's where a lot of cosmetic dentistry is really going now, is how do we temporize these patients to make sure that the bite is correct, to make sure that the color is correct, to make sure that the function is correct.
Right.
And
yeah, if you're doing it well, your provisional prototype is exactly that, the prototype of your final restorations. Right. And you're not moving past the prototype until everybody's on the same page. I like it, you like it, and it functions. But you're right, that is not happening all the time.
I think in temporaries you get shape and you get function, but you don't necessarily ever get color. I mean, like the bleach shade temporaries is never going to look as
it's tough
as multi-chromatic as the permanents will. And so, I mean, you can throw it out there and it's, like my favorite analogy is that patients, think they want one shade and it's BAW, butt ass white. And then when they get butt ass white, they realize, oh, maybe I didn't want butt ass white, and so, it's I think it's kind of hard to temporize. I mean, the lightest I really like to go on temporaries is A1, because if they want it lighter, I can get lighter.
I will put bleach temporaries.
Is this a Texas problem?
All day long.
I do bleach temporaries, but the lightest I'd like to go is A1.
Yeah.
A1, B1. I mean, that's the lightest I like to go because I still have a little bit lighter than I can go. If I go bleach, I don't know if I can go much lighter than that.
No, I don't want to go lighter. I want them to see what bright ass white looks like and to see, do I want to be Brett Baird, gleaming out where my teeth come in the room before I walk in the room, or do I want to have a natural looking smile?
I mean, these aren't quite as white as I remember they were on the show.
No, they're just big.
Yeah, they're just big. They're big.
I think there's 6 centrals right there.
Yeah, I think so too. No proportionality whatsoever.
I got to tell you, my patients, there is no temporary material white enough for my patients.
Yeah.
And there's a lot of ceramics that are lighter and brighter and whiter than the whitest temporary material that we have. So,
so what do you do?
I put them in the whitest thing we have, the temporaries, and then they say, this isn't quite enough. And then we lighten them up in the ceramics, but always with a gradient, right?
And give them 14 by 10 centrals.
And you give them a couple of cataract contacts.
Chiclets.
But have you ever, I've been whitening teeth for 25 years. Have you ever had someone say, no, my teeth are too white? Never.
Shit, no.
I mean, not one single time.
Shit,
Never
no.
have we had the Ross on Friends situation.
Never. Not once.
Thousands and thousands of teeth.
No.
The glow.
I know. I was looking at a case this week, and it was a really lovely case that ended up happening. And I love her temporaries more than I love her finals, because her temporaries are a B1 and they naturally look so much more normal in her face. And then you see the final, it's like, bam!
Yeah, I know.
1-in-1. I feel like I should just carve it in.
Hey, next conversation we're going to talk about tooth jewels.
Oh. Do you do tooth jewels, Susan?
Yes.
And
my most watched video ever on Instagram is me bonding a little flower I can never say this word, Swarovski crystal onto someone's lateral incisor.
Right on.
Really?
I really like blood, sweat, and tears, made videos of what I thought were really important techniques. Yeah. Everyone wants to see how to bond that Swarovski crystal on there. You have to, so yes, I do teeth gems. You have to be careful to use, right? Like no lead in those crystals, because a lot of the things that you can buy online to do it are not biocompatible.
And are you just wrapping it in like a flowable?
Yeah. A little touch, little bond, a little flowable, drop it on and cure it. And they have to come back to get it off, right? It never comes off.
Yeah. And for those who are curious, like, are you creating any indentation in the tooth so it's flush, or it's just sitting on the surface?
It's sitting on top of the tooth. Okay. I don't prep the tooth at all for that.
Yeah.
And is there any sandblasting of the crystal to enhance bonding?
That's a great idea. No, I've never done that. It sticks on there, but I love it.
So I love it.
You better have the right side.
But here's the deal.
Yeah, exactly.
Even if you get it on the intaglio surface, I think it would affect the fluorescence of the crystal, because the sandblasting would affect the light transmission through the crystal. So I think you've got to be real careful with that.
Interesting.
Yeah, I've also done
some a whole conversation.
Yeah, real diamonds, but they come from the jeweler set in a little basket, and so it sits up off the tooth a little bit.
Yeah.
So otherwise, it doesn't reflect like a diamond does. You need that engagement ring up on the basket. You can't have it flush.
Yeah, it's the gift that keeps on giving.
He went to Jared.
Have any crystals? I don't have any on me.
I don't have any crystals. I probably should get some.
Chad went to Jared.
Yeah, I did. The Gallery of Fine Jewelry.
Yeah. You would totally go heart-shaped jewelry. I know it.
Yeah, I would.
Just a heart right there.
Guys, we are beyond time.
It's because we're hanging out with a bestie.
I know. It is
fun for me.
Chad, I think we have to close out. Susan, thank you so much. Love hanging out with you. And damn you for not hanging out with me more, being as close as you are. But we'll get into that after hours.
Yeah, we're not actually talking about her current location.
That's right. Chad, close us out.
So first of all, thank you, Susan, so much for being here. I was actually talking earlier and I was like, God, nobody's listening to me. And then I realized that I had muted myself. So none of my voice was coming through. So I was trying to chime in on a couple of things, but I couldn't. And that's probably for the better. But I think there's a lot of takeaways for the night. But the biggest takeaway that I have.
Is he frozen to you too?
Froze?
That's so ironic. He was mute for some portion of the show and then he froze up.
Yeah. Well, you know what, Chad? None of us really wanted to listen to you anyway.
Second.
That's
Am
right.
I back?
No.
Am I not back?
Oh, now you're back.
What the hell just happened? That was a StreamYard thing, because I could hear everybody and everything just kind of went.
I don't think it was StreamYard, Chad, because we were all still running a show over here.
Okay. Well, then I'm going to go ahead and start over.
Maybe you need to stop the StreamYard Quaaludes.
Speaking of Quaaludes. Anywho, I think the most valuable lesson tonight was listening. And so I'm just going to close it by saying, one of my favorite phrases is that sometimes you're the faucet and sometimes you're the sponge. And I think that as dentists, we need to be the sponge and we need to listen to what the patient has to say, because we will learn so much by taking in what they have to say. And then once we've taken it all in, digest it for a bit and then respond. Don't just respond in a reactionary manner. So listen.
I hate it when he says something smart at the end.
Listen,
because people actually think he's smart. I know.
Listen.
And I say sometimes you're the bug and sometimes you're the windshield. Like, these are very different mottos.
Have a good night, everybody.
And that wraps up up another podcast for Dentists in the Know. On behalf of Dr. Jennifer Bell, Dr. Chad Duplantis, and myself, remember that we've got a great profession, so let's make it a great day, Dinks.